studies with real outcomes like this one. Subjects diagnosed with Alzheimer's disease had their statins stopped for 6 weeks, after which their cognition was then again tested. And guess what? 6 weeks after stopping their statins, their cognition had improved. So then the investigators resumed the study subjects back on statin therapy and tested their cognition again after a further 6 weeks. And guess what happened? Their cognition declined. Very suggestive that maybe some of what is diagnosed as dementia might actually just be statin side effect. Still on dementia, we have this more recent study that found statin therapy was associated with a more than doubling of dementia risk. And using scans, they were able to demonstrate impaired brain metabolism in the statin group. And still many doctors will genuinely believe that statins can't influence cognitive function. Statins may also increase the chance of developing diabetes. The Women's Health Initiative study found a 71% increased risk of diabetes in those taking statins. And if you want to learn more about the wide array of potential side effects from statins, I suggest you visit crestor.com and click the prescribing information link up in the top right. And buried within the text, you'll see references to liver damage, muscle damage, blood in the urine, worsening control of diabetes if you have it, and increased risk of developing it if you don't. You'll be advised to exercise caution in using Crestor over the age of 65, no doubt related to the increased risk of side effects in this population. And in the post-marketing section, my favourite, you'll see that numerous adverse reactions have been reported, including fatal liver failure, nerve damage, dementia, and muscle destruction. Other post-marketing surveillance data is even more confronting. Data from the FDA suggests an increased risk of amyotrophic lateral sclerosis, also known as Lou Gehrig disease, with the statin atorvastatin. A risk of 107, not 107%, 107 times, more than 10,000%. Another statin, simvastatin, has been associated with an increased risk of motor neuron disease of 57 times. And despite these shocking numbers, we still don't have any prospective studies delving further. For some reason, it seems drug companies are not interested in pursuing this line of research. Some of you may now be asking, if I'm going to be risking these side effects, how beneficial are statins? The best metric, I believe, to answer this question is longevity. That is, will statins make you live longer? You see, death is a hard endpoint. It's difficult to fudge. Research using soft endpoints, surrogate markers like blood LDL levels, don't necessarily reflect reality. For example, you've seen how, on average, people with high LDL levels live longer. Therefore, using LDL as a surrogate marker for cardiac risk, as many studies do, is fundamentally flawed. Now, I often hear the spurious argument that we should not use lifespan as an outcome measure because health span, that is the period that people remain healthy, is more important. The fact is, people who live the longest also tend to be the healthiest. That is, they have a longer health span. When you think about it, this is rather obvious. People who live the longest and don't die of, and I quote from the paper cited here, chronic illnesses that fell the younger elderly. Yes, you can be ill for 20 years and die at 80 in a nursing home, but in Australia at least, that is still less than the average lifespan. Healthy people, they're the ones who live to the ripe old age, not the sick. So back to the question, do statins increase life expectancy? And the answer is, it depends. It varies depending on whether or not you already have heart disease. If you don't have a history of heart disease, then the goal is to prevent you from getting it in the first place. This is what we call primary prevention. Secondary prevention, on the other hand, can be thought of as preventing a second episode of heart disease. And statins for primary prevention are really not much chop. This is a meta-analysis of randomised control statin trials for primary prevention. That is for people without heart disease. If you haven't yet had a heart attack and you don't suffer from angina, you're probably in that group. And it concluded for those between the ages of 50 and 75, there was no mortality benefit from taking a statin. In fact, of the 8 trials reviewed, only 1 found a mortality benefit. This one, called the Jupiter trial. In my experience, it also happens to be the most commonly cited piece of evidence used by cardiologists when they try to convince their patients to take statins. Now, you'll recall that the premise of the lipid heart hypothesis is that high LDL levels cause heart disease, and that statins are presumed, by lowering your LDL level, to reduce the risk of heart disease, which makes this trial strange from the outset. You see, they excluded subjects with high LDL levels from participating. They then required all subjects to have an elevated CRP, a marker of inflammation strongly associated with heart disease, moving the bar towards a secondary prevention population and certainly not representative of the general population. Things get even murkier when you consider that this trial was stopped early, despite not meeting the pre-specified threshold for early termination. The investigators broke their own rules, which they set before the study began. And don't think that this is just worrying about esoterics. It's well established that trials which are stopped early tend to exaggerate drug benefits. And the Jupiter trial also provides a textbook example of misrepresentation of research findings to the public. This article reported that statin users were almost 50% less likely to suffer the effects of heart disease. This is what the reality looks like in absolute terms. You can see that the magnitude of benefit in real terms was underwhelming. Using relative data like they did is inherently misleading. How then do we get review articles like these 4, which all extol the benefits of statins for primary prevention? The reason is they all include ineligible studies. They claim to be assessing a primary prevention population, and yet they include studies on secondary prevention populations. Basically, they draw conclusions on the benefits of statins for people without heart disease by using study data obtained from people with heart disease. The fact is, when reviews do not include ineligible studies, no mortality benefit for statins in primary prevention is found. This recent review provides a scholarly analysis of the topic, concluding that the small reduction in cardiac events with statin therapy is outweighed by significant adverse effects. Further, they point out that the calculus is even worse for the elderly, seeing no benefit with an even greater risk of harm. That one of the authors is both a cardiologist and a past editor-in-chief of the Journal of the American Medical Association is also telling. I think it's safe to say that these ideas can no longer be considered fringe. The fact remains, however, that there is some evidence of mortality benefit with